Hey, Becky.
Hi, guys. Hi, Don. Hi, Brooke. Hi, Fabian. Glad to see you again. Hi, Geneva. Hi, Julie. Hi, Melinda and somebody. Hi, Nicole. I like doggies.
He's my cloudy boy.
What's his name? Cloudy?
Cloudy.
Oh, so cute.
His
Fluffy like
hair
a cloud.
Yeah, his hair is so soft. I'm growing it because I want to make a blanket out of it.
Oh, wow.
Yeah.
That's awesome.
Yeah.
We have a Canadian visitor.
Hello.
Hey, I'm not leaving you guys. It's like 80 degrees in here. Let me go fix the heating and cooling system. I'll be right back.
No worries. Hi, Darren. Welcome. Good to see you.
Hello. Good to see you too.
Well, before Dr. Becky gets back, just really quick, some housekeeping things. The session will be recorded so that we can have it on our website for families to come and watch later on. A lot of people couldn't decide between two sessions, so we figured recording would be the easiest way, and that way it's accessible later on and not just during the live version. Feel free, if you feel more comfortable with your video off, not a problem. For this, if we could stay muted, but you're welcome to unmute if you have questions or want to ask anything or add anything during the session. But I'd like to introduce you all to our amazing Dr. Becky. I can honestly say she's the medical director that will go and lead arts and crafts or go paddle in a canoe or do anything she can to not be the doctor. Not that she wants to get out of it, but because it's usually so quiet in the health center at camp that she would much rather get out and be with kids and play and get on the floor with them and do what we all love doing. So take it away, Dr. Becky.
Hey, guys. Can you hear me okay? Awesome. Good to see familiar faces. You know, I always get anxious about these things. I don't know why, because like this is probably anxiety and depression, hearing about it, recognizing it, treating it is probably 20% of what I do in my life. But giving these talks is always anxiety producing. So my hope for today is that you guys will leave with a more, if you'll forgive me, correct view of mood disorder. It blows me away that I was in medical school. So I'm a mom, I'm an internist, I've been in practice. I counted it up this morning on my run, 34 years, not counting my training. I probably see 80 patients a day, and probably 20% of those visits have to do with mood disorders. So we've got a boatload of experience. I also have mood disorder in my family. And so know that I am coming to you in hopes that I can give you some of my experience, strength, and hope, and hope that you will have a more correct understanding of what mood disorder is and is not, and believe that it is not chosen or a character defect, and that it's totally treatable. So how's that sound? Good? Good? Okay. The first two, let's see. Let me see if I can share my screen. We're going to see how techie I am. All right, can you guys see that? Yeah? Okay. And you can still hear me, right?
Yes, you're good.
Cool. All right, so we're going to talk about anxiety and depression. I think that whenever a topic like this comes up, we all ask ourselves, could I be affected? Could someone I love be affected? And if so, what do I do? So I hope to answer that. The first two slides, I put them the first two slides because I'm hoping that you can get through like 3 to 4 minutes without falling asleep, and trust me that the rest of the talk will be more interesting and less full of numbers, okay? Yes, I'm a doctor, but we are not going to talk about biochemistry. We are not going to talk about a zillion statistics. I've got a couple statistics, and I'm going to have a really messy slide too. And I guess slide 2, which is this one, has numbers. My apologies. Slide 4 has way too many words, and I'll tell you why. But the rest of it is going to be very palatable and practical, and I think usable. So mood disorder. What is mood disorder? Mood disorder is mostly what we call unipolar depression, which means just plain depression, not bipolar disorder, and or anxiety. The two coexist together a large amount of the time. And lifetime prevalence means if you look at 100 people and their whole lives, 30% of those people, or 30 of those 100 people, will have a significant episode of anxiety. 20% of them will have a significant depressive disorder. Now, I'm not talking about I'm anxious because my kid just got a new diagnosis, or I'm depressed because I just lost my job. That's not what we're talking about today. We're talking about disorders. So those are pretty high numbers. Like if you think of like the last 10 people that you saw, at least on Zoom, 3 of them have or will have had a significant episode of depression, 2 weeks or more of feeling depressed to the point it interfered with their life. And 2 of those 10 people that you're imagining in your mind, 30% will have had a significant episode of anxiety, which actually is 6 months of pervasive anxiety. 2 of those 10 people will have had a significant episode of depression, which is at least 2 weeks of feeling depressed with some other stuff. So that's really common. At any given time, 20% of Americans suffer from mood disorder. Interestingly, it's way more common in America than in other countries. We don't really know why. PTSD is also way more common in America than in other countries, even countries that have significant stressors like poverty and tsunamis and that kind of thing. Nobody knows why that is. But at any given time and space, so like let's say on October 8th, 2020, 20% of Americans, this is not during a pandemic or right before an election, 20% of Americans are suffering from either significant anxiety and disorder. Now, probably 20% aren't. I don't know. That's not a real number, but it's tough right now. This is really common. Depression and anxiety disorders often go together. So I often tell patients, depression and anxiety are heads and tails of the same coin. The biochemistry, interestingly, is very similar. So if I'm feeling depressed or I'm feeling anxious in a long-lasting way, those feel very different to me, but their base, their biochemical and electrical base are very similar. Depression and anxiety are more common in situations that you'd expect. So they're more common in people who have experienced significant trauma. Guess what? Having a kid with a significant illness is significant trauma. Being an emergency room doc or a firefighter is significant trauma. 70% of them, if they've done studies, like they've sent out studies, sorry, I have one more statistic. I have a bunch, I'll threaten you with them. If I see anybody fall asleep, I'm gonna start spitting statistics at you, especially you, Darren. So anyhow, they've done studies looking at mood disorder and PTSD, and if you send those studies to any group of Americans at any given time, and you ask them, have you had a significant traumatic event? And they'll give examples of it, like things that you and I would think are significant traumatic events. 70% of people have had some significant traumatic event in their life. That predisposes you to mood disorder. Being a woman or a girl predisposes you to mood disorder. Childhood trauma predisposes you to mood disorder. And the one I want you to think about trauma, because everyone listening to this talk has had significant trauma. And I want you to think about family history. Mood disorder is a biochemical disorder. And like I always tell my patients, I'm a white female. I didn't choose that. I might have preferred to be a black male, but that's not how I was born. My parents' genetic makeup led me to be a white female. I don't get to pick that. The same is true for mood disorder. You don't get to pick if you have a predisposition to depression and anxiety. It's just the cards you were dealt. So I'm hoping that it blows me away that I can literally remember being in med school at U of M and having them impressing on us the relatively new knowledge that mood disorder is a biochemical disorder. It's not a character defect. It's not something you chose. It's not some woman going through menopause. It's a biochemical disorder. Okay, I graduated from med school in 1984. We have not made it very far. So I'm hoping that our little cadre of people listening to me babble on today will at least leave believing that I could literally bury your house in evidence that this is a biologic disorder. And I hope that you will trust me on that and begin to change the way you think and change the way the people around you see mood disorder. So when do I suspect mood disorder? Like, when should I be thinking about this? And I'm not trying to make you guys into clinicians who can then come, though I am looking for another employee if you're interested. I'm not trying to train you to come in here and work in my office and screen all my patients, get their blood pressure, and then figure out if I should be thinking about mood disorder. That's not my goal. My goal is that if you're, on a Zoom call with your cousin, or you're talking to your adolescent, or you're listening to your spouse, that, you're talking to your best friend, that you will listen and be present and think about the possibility that they may be suffering from a significant mood disorder. And I'm going to challenge you later today to go a step further and give them permission to get help. So when do you think about it? Well, stating the obvious: depressed mood or loss of interest in pleasure or most of all activities. I had a time when I felt like, I don't know if I qualified for a mood disorder, but I felt depressed a good part of the time. I probably did. I wasn't interested in doing things. I wasn't getting together with people that I loved and cared about. I wasn't running. I went to my physician and said, I want to go on an antidepressant. And he said, you need a new job. He was right. The feelings went away with that. But if you're hearing someone talking about, I just don't feel like doing anything. I don't feel, even going to the grocery store with a mask on, even doing a Zoom call with my besties, I don't feel like doing that. I love to cook, but I'm not doing that. When's the last time you made a meal? I don't know, maybe a month ago. That may be depression. With families who have been affected by significant illness, we're going to have feelings of helplessness and hopelessness. That's normal. None of our kids or our loved ones chose to deal with what they're dealing with. You certainly didn't. You're going to have times that you feel helpless and hopeless, but that shouldn't last. It shouldn't be pervasive. You should be finding hope. Listening to some of the talks we've had the last couple of days, hopefully is giving you a sense of, I might be able to find this little way to better take care of myself, or connect up, or get somebody to watch my kids, whatever it is. Irritability, and hopefully you won't accuse me of being sexist, but particularly in men, irritability and anger may be a sign of depression. My second patient today was a guy who I know well, happily married, has a new kid at home, kind of in his late 20s, professionally successful. And he said, I'm mad at my young toddler and my wife, and it doesn't even make sense to me. Turns out he was experiencing a significant clinical episode of depression. We got him on treatment. Anxiety speaks for itself. Obsessive rumination is a symptom of mood disorder. It's things like, I'm out to dinner with my spouse and all I can think about is, I'm afraid my son's gonna die. He's gonna have to go to the ER. It's intrusive. So yes, you're gonna be sitting and cooking and thinking, gosh, I hope that this fever isn't, COVID or port infection or whatever it is. But when those thoughts just keep rolling around like your, thing that's in the dryer that shouldn't have been put in there, that's obsessive rumination. Phobias can be a mood disorder. It might be just a plain phobia. So, you're afraid of snakes. That's probably not a mood disorder. You're afraid to go out. That may be a mood disorder. Excessive concern about your physical health. I have patients that come in twice a month. The worried well, that may be anxiety disorder as opposed to something else that we have yet to diagnose. Chronic pain can sometimes be or cause a mood disorder to come about. Also, the last thing that I've got here, just wanted to suspect mood disorder, is when there's a family history. Like, that is so strong. If someone that you know and love has a family history of someone, like my sister tried to kill herself when she was a mid-teen, that alone should put my physician's radar screen up that I might come in with a symptom that may be mood disorder. All right, brace yourself. This last slide, we're going to get by this last slide, and then the rest of it's going to be really practical. This is practical too, but don't take a deep breath. Here we go. I want you to look at this slide, and I'll give you a link to these in a minute when I'm not talking, and I can do that more easily in the chat room, or Sissy, if you're listening, and you can put the links to this talk and to the depression and anxiety questionnaires, that would be great. So let me talk for just a second about why we have diagnoses. That's probably not something you guys have thought about. So why do we diagnose a kid with a heart condition? It's so we can treat it, right? Like, if we don't do the cath and make the correct diagnosis of the correct congenital heart disease, we won't be able to treat it. Why do we make the diagnosis of sickle cell? So that we can respond appropriately, so that we can make sure that this kid/patient doesn't get cold, that they have appropriate pain medication, that we respond to symptoms in a different way. We have a diagnosis for treatment. If we call depression like maple syrup disease. No, there is a maple syrup disease. Trash can disease. I'm looking out my window. Like, it doesn't matter what the name of it is. It doesn't matter it's called depression. All that matters is that we make a diagnosis so that we can get treatment. So the reason we have the diagnoses of depression and anxiety and anything else, hypertension, coronary artery disease, pneumonia, I don't care what diagnosis you use, the reason is so that we can treat it. So we have learned that, I just screwed up. Hang on, there we go. We have learned that the better we are at making a diagnosis, the better we are at treatment. So for instance, if I have chest pain and my doctor sends me for a cardiac cath and they find that my left main is almost completely shut, then they know that they got to either roto-rooter that out or give me a new artery there so that I can, so they can treat the problem. Like, we do a very specific test, in that case a cardiac cath, in order to give the proper treatment. For depression, we want to be, I can't do a biopsy, I can't send them for an MRI. Like, how do you make the diagnosis of depression? And it's been studied over decades and decades and decades, and this is how. And I will send you guys this slide, because although this is written for doctors, it is, you don't need an MD after your name to read this stuff and figure it out. So depression means for 2 weeks, this individual has had a depressed mood or loss of interest and pleasure 2 whole weeks, doesn't stop, doesn't go away. And this depressed person also has to, at the same 2 weeks, have 5 of this list of symptoms, okay? So this is our equivalent of an MRI for brain cancer, or cardiac cath for chest pain. This test that I'm giving you right now is our gold standard for depression. So for 2 weeks, the person feels depressed or is not interested in anything. And they've got at least 5 of these things, and they're listed here. Depressed mood or loss of interest and pleasure, those can count as 2 of the 5 things. Weight loss or gain, so it can go either way. People with significant depression might, eat a lot and gain weight, or they might just not feel like eating and lose weight. The next thing on the list, number 4, is insomnia. They might have trouble sleeping. They might also sleep too much. So like, the classic symptom that we think of with depression is the person who doesn't get out of bed. They also may have trouble sleeping. Number 5, these are big words, I'll explain them. Psychomotor agitation or retardation. That means people are super hyper, clipping their, you sat next to these people, clipping their leg up and down, dun, 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 can't sit still. Or maybe they're just sluggish. They're sitting around, they don't want to move, they're curled up on the couch. Again, either way can indicate depression. So I hope I'm challenging you to think, oh yeah, the depressed person isn't just the person who's sitting at home and won't go out and doesn't move and is eating too much and sleeping too much. It might be either way on any of these symptoms. The next possibility to fulfill 5 of the other things that have to go along with depressed mood is fatigue. So just feeling, more tired than usual. The next thing is feelings of worthlessness or excessive and inappropriate guilt. It's all my fault that my kid has, epilepsy. I'm not worth it. There's no sense in me, buying that thing on Amazon that I want, or taking that walk even 3 times a week, or going to buy the thing that I want at the grocery store because it sounds good to me because I'm not worth it anyhow. That may be depression. Next on the list is decreased ability to concentrate, okay? Not people with ADD who are not treated, but if you've got someone who literally can't make decisions, that may be a sign of depression. And finally, recurrent thoughts of death. And we'll talk about suicide just a little bit later. But if there is someone who says, I've been thinking that I just want to end it all, and I've, got a bottle of Tylenol and I know where it is and when I would take it, that is a trip to the ER. It's also one of the potential diagnostic criteria. Even thinking about, I wish the world would be better without me. That may be a symptom of depression. So 2 weeks of depressed symptoms, 5 of the list of 9 things we just went through, and 2 other things, and then we're going to get off this slide and take a deep breath. The other thing that has to be true is that those symptoms get in the way. So maybe I'm feeling depressed, but I'm still going to work, I'm making nice meals, I'm getting out with my friends. That's probably not depression. The symptoms that we just listed are interfering with your life. They're causing distress. And finally, the symptoms are not due to something else. So like a medication, steroids can cause depression. They can also cause anxiety. If you've got somebody who maybe is on chemotherapy and they had to be on oral steroids for a month and they're depressed, that's not depressive disorder, genetically predetermined, that's steroids. Someone who's had a stroke, maybe my child with sickle cell unfortunately suffered a stroke. They may feel depressed for 2 or more weeks afterwards. That may be due to the stroke. That may not be, in addition, an underlying diagnosis of a biochemical depression. Okay, congratulations, you guys made it and you're only stuck with me for another 25 minutes. I'm gonna give you something more interesting. Let me put this in the chat room. Bear with me. I know you're stuck looking at my email for a minute. Hang on. I am gonna stick this. Hang on, bear with me. Stay tuned in our chat. I think I am going to have to, let's see. Hang on. I am going to stop sharing for a second so that I can stick this in the chat room. All right. So I just sent you guys some links. I'm going to go back to screen sharing. You can cut and paste those links into some other place that you can go back to them later. I'm going to challenge you guys to take 2 minutes to look through this self-questionnaire for depression. This is called a PHQ-9, and you will now be able to print this up. You might give it to a friend that you feel comfortable with and are concerned about. You might spot check yourself in a couple of months to see, hey, do I fit the criteria for depression? I talked about the symptoms that go with a diagnosis of depression. If I sat down with my patients and went through that slide that you just are now recovering from, they would either leave or be asleep. We don't do that. We give people a self-questionnaire, and this is the questionnaire that every physician is going to use. It's called a PHQ-9, and if you guys want to, just take a minute and go through it. I'm not going to ask anybody what their score is, but I'm going to stop talking for a second and let you.
Dr. Becky, did you put some things in the chat? You said some links.
Did it not work?
I didn't see them. Could you make sure that it's to everyone instead of to maybe one of the hosts potentially?
Oh, no, the problem is I didn't. Why won't it post?
I know I've had trouble like copying and pasting things like links and stuff into chats on Zoom. I know Zoom's kind of finicky with that stuff.
Huh.
We could email those if that's easier.
Yeah, that'd be great.
Okay, I'll send out an email. If you just shoot them to me, I'll send an email out by the end of the day to everyone in this.
Okay, that sounds great because I really want you, thank you, Jess. I really want you guys to have these because it's the exact same tool. They're like, you do not need, trust me, you do not need an MD or any other funky initials after your name to make a diagnosis of anxiety and depression. And I want to give you the tools so that you can do that. So let me go back to screen share. Jess, thank you. We'll send you those questionnaires, but can you see that PHQ-9 questionnaire, you guys? Yeah? Okay. I want you to take a second and just fill that out. Somebody give me, it isn't working, Melinda? You're on mute.
I can't see it.
Let's see. Let me see. I can only delete the slide. I can't move that big red box that
Yeah.
I can only, can you see it?
Yeah, I could see it.
This is a real weirdness about Zoom. Can somebody like let me know they're done?
Wow. That's my dog snorting.
Can somebody give me a thumbs up when you're done, just so when I see a couple, okay, thanks. Okay, so add them up. So you take your mute off if you have a question.
I can see the questions, but I can't see the score system.
Okay, so I'll tell you what it is. Can you see the 0, 1, 2, 3?
No. Just the zeros, the whole column of zeros, but not the other numbers.
Curses. Spoiled again. Okay, we're not gonna belabor this because we've got 15 minutes left and I want to make sure we stay solution focused. Jess will send this to you guys. The gist of it is every one of those questions you see, like little interest or pleasure in doing things, then it says, do you never have it? Do you have it occasionally? Do you have it most days? You know, you get a number, 0 to 3, and then you add the numbers up, and then you can see the big red box. And I should have put this on 2 slides. I didn't know it wouldn't show up. You look in the big red box and it'll tell you, like, this is suggestive of minimal depression. It's unlikely you're depressed. 5 to 9, you probably are mildly depressed, etc. 20 to 27, you're severely depressed. You ought to call somebody. So that we will email that to all of the participants, everyone that signed up for this session. We will email you that, and then in a minute we're going to have a similar questionnaire for anxiety called the GAD-7. And again, these are the exact clinical tools that 99.9% of clinicians would use if you came to the office and you and or the healthcare provider was wondering about anxiety and depression. Let's move on. Let's talk a little bit about anxiety. So the diagnostic criteria for anxiety is different in symptoms and in duration as compared to depression. Anxiety disorder means that you have had excessive anxiety and worry about a bunch of stuff for at least 6 months. Really different than depression, okay? That worry is pervasive, it's difficult to control, it comes into your thoughts when you don't want it to, and it's the same kind of thing again. So we've got depression, it was depressed symptoms for 2 weeks, and then this other stuff, and it interferes with your life. Anxiety is anxious symptoms for 6 months, and 3 of this list. Restlessness or feeling keyed up and on edge, being fatigued easily. That's one I see a ton in the office. People come in, I'm fatigued, there's something wrong with me. They want to build a zillion tests. And we'll do like a reasonable number of tests, but I usually know the minute they show up, they're anxious. Like you can feel it, the room is vibrating. You know, I think twice and take a deep breath outside the room before I go in. You know, people who are fatigued are often actually anxious. It's exhausting to be anxious. Think about the last time that you were at the hospital and that anxiety, you come home, you are bone tired. It's exhausting. So being easily fatigued or feeling fatigued may be anxiety. Again, as with depression, anxiety may present itself as difficulty concentrating. The most common cause of memory disorder in older adults is actually not dementia, it's anxiety and depression, which may come as a surprise. Irritability, again, can be a symptom of anxiety disorder or depression disorder. Muscle tension, so like, hopefully my daughter will never listen to this talk, but sometimes her face gets so tight that like, I think she might break it. That muscle tension, I know right away, she's in an anxious time. Sleep disturbance, it might be difficulty falling asleep, restless sleep, or staying asleep. And then, just as with depression, those symptoms of anxiety screw up your life, okay? It's not like I'm anxious because my mammogram was abnormal or my kid just got a new diagnosis, but I'm able to like cope with that. We got a doctor's appointment in a week. You know, that's not anxiety disorder. That's normal anxiety. So it's anxiety that goes on for 6 months. It dribbles over everything. It's associated with at least 3 of these other things we just talked about. And it's interfering with your ability to live a fulfilling life. There is a questionnaire for anxiety. I'm going to email that to you guys, but this is very usable. And it's something like with my patients who I'm treating with medications or therapy for anxiety and depression, we will do this each time they come in. I saw somebody yesterday whose GAD-7 was like 17. And yesterday, we started her on Lexapro, I think it was, some medication. She came in yesterday, well, I think I'm a little better. Well, I gave her the GAD-7. Her score had gone from 17 to 3 in a month. Holy crap, yeah, I guess you are. But this numeric tool really helped both she and I. I sent it home with her so that she could actually assess, you know, what are my feelings? Could they be anxiety, and am I getting any better? So it's a good tool for both. I want to talk for a minute about what are depression, anxiety, what is not depression, anxiety. So they are a biologic condition. Depression, anxiety is not the same as PTSD. So PTSD, I wish we could talk about it. It's super important. Very, very common in families who have suffered an individual with significant illness, be they the parent or the child. PTSD is things more like hypervigilant, avoiding situations that remind you. I have patients who I've told once they have cancer and then they have another significant symptom, they don't want to come back in and see me to even talk about it because they have PTSD from the first diagnosis. Panic disorder is not a simple anxiety or depressive disorder. By simple, I don't mean like negligible, I just mean uncomplicated. So panic disorder, the first person I ever saw with panic disorder was a good friend of mine. He and his wife watched my first son while I worked. He was an accountant in Detroit, and he would get, he lived in Ypsilanti, in his car and be driving to Detroit perfectly calm and suddenly just be, he'd have to pull over. He was terrified, his heart rate went up, he had no idea why. That's panic disorder. Psychosis is not knowing the difference between what's real and what's not. with people who have mood disorder, they know what's real and what's not. Like I may just be feeling anxious all the time for the last 6 months, but I know that's not a response that really makes a lot of sense. You know, the last 6 months, it probably does make a lot of sense, poor example, but you get what I'm going for. Psychosis is, I'm lying in bed and I think I see and hear little children walking around while I live with 2 black labs. You know, that's psychosis. Grief is also not anxiety and depression, and they may coexist, but we wouldn't diagnose someone, for instance, whose child just died or who just got a divorce necessarily with anxiety and depression. They may be experiencing grief. I just want to say a word about bipolar disorder. Bipolar disorder is episodes, we're not going to like bore you with a lot of this, but it's people who feel depressed but also are super hyper. Like maybe they're depressed and sitting at home for a month and then they go gambling and spend, you know, $5,000, or you know, teenager goes and has sex with 5 different people. Bipolar disorder is super hyper, spending too much, having, you know, sex that doesn't make sense with your partner. That's an oversimplification, but I just want you to be aware that there is such a thing as bipolar disorder or manic depressive disorder. It also is a biologic thing. I have a very close physician friend who has this. She's on great medication. She's had a lot of therapy and you'd never know it. It's a genetic disorder. We treat it a little bit differently than unipolar depression. We talked earlier about anxiety and depression might be induced by something like steroids or a stroke. And then just wanted to say that substance use disorder, it might coexist with mood disorder. So like a lot of people these days, I live near Ann Arbor, everybody wants medical marijuana. And a lot of people think that that will decrease their anxiety. There is really solid evidence that marijuana actually, you know, THC increases anxiety. But a lot of people use drugs and alcohol. I would say since we started this pandemic period, I have heard more people tell me they were drinking too much than ever before. And for every person that tells me that, there's probably 5 or 10 who's not telling me that. Like misuse of substances and or addictive disorders commonly go along with mood disorders. But they're not the same thing and we treat them differently. I'm going to blow by questions for a minute so that I can do these last 2 slides and we've got 5 minutes for questions. I just want to tell you guys, these are like eminently treatable diseases. We are good at treating anxiety and depression. The vast majority of people who suffer from these disorders can get relief. Some of them, it may be simply developing a good diet and exercise plan. For many people, we're talking about therapy and or medications. But there's no reason for someone to suffer from mood disorder. It's super treatable. The most common medication that we use is, oh darn, I skipped 2 slides. I'll go back, is serotonin reuptake inhibitors, which are things like Prozac, Zoloft, Paxil, that kind of thing. There are a bunch of other medications and treatments that we use. We're very, very good at that. I don't know how I skipped slides, you guys, and I apologize for that. Let's go back. I want to go back to a word on biology. As I said, mood disorder is an imbalance of chemical and electrical signals in your brain. It's primarily in the limbic system, which is an area deep in the brain. We're learning more about this every day, but it's a lot of mood disorders due to signals being too active in the amygdala, which is an area deep in the brain. We can see it on PET scan. If I take a patient, there are lots and lots of studies of patients who came in, they had anxiety and depression. We did a functional PET scan and then we repeated it 6 months later after they'd had treatment. Dramatic improvement in signal activity. We can actually see the difference that it makes. It is not a character defect. People are not choosing to be depressed or anxious any more than they're choosing to have epilepsy, sickle cell, congenital heart disease, any of the things. This is a medical disorder, and we are actually able to, we can't change your genetic makeup, but we can change the way that the chemicals and electrical impulses are acting in your brain with everything from meditation, Tai Chi, diet, exercise, lots of different medications and therapy. Just a word on suicide. Suicide is the 10th leading cause of death in the United States. It's the 3rd leading cause of death in adolescents, in late adolescents, 15 to 19. Suicide is highly linked to depression and substance use disorder. It is, in my opinion, the ultimate tragedy. Many of the quick decisions that we make in life as human beings are fixable. If I run a red light, if I get married to somebody that it doesn't work out with, if I, buy a house that ends up, not being good for me, these things we can fix. Suicide, if an individual goes through with it and we are not able to find out what they're doing quick enough and intervene, that is the ultimate tragedy. I hate the term a person, quote, committed suicide. I like to use the term suffered suicide. And I just want you guys to realize, like, you can make a difference. If someone suffers suicide that you know and love, that is no one's fault. That being said, we may be able to make a difference just simply by asking difficult questions. Are you okay? I've been worried about you. There's a suicide hotline, which I've put the phone number and the website on, that can give you some ideas on how to ask those difficult questions. University of Michigan has actually an excellent community section on both mood disorder and on suicide prevention. So I will send you those resources so that you can look through them. But don't be afraid to ask someone if they need help. How do you get help for mood disorder? Most mood disorder is treated by primary care physicians. Go and talk to your primary care physician about it. If they're not hearing you, go to a different one. Most people don't actually need a psychiatrist. You need a psychiatrist if you've got a coexisting disorder. You probably, in my opinion, need a psychiatrist if you've got, for instance, mood disorder and a substance use or addictive disorder. You need a psychiatrist if you've got a psychosis, you're schizophrenic, something like that. You need a psychiatrist if the first 2 or 3 things that your primary care doc is trying to help you relieve your symptoms and treat your disease don't work. We may want someone who does this day in and day out, but literally 20% of what I do as a primary care physician is treat mood disorder, and your primary care physician is going to be no different. If you or someone you know is turning to drugs or alcohol, there's help for that. This talk doesn't give us a lot of time to talk about that, but if you just Google search anything like what to do if I'm turning to drugs and alcohol, a bunch of resources will pop up for you. Cost of treatment is definitely a barrier, but not as big a barrier as you might think. My sister, as I said, suffers from mood disorder. I just visited her in Oregon in July, and I could tell she wasn't on treatment. I said, well, why aren't you on treatment? Well, I can't afford, I don't have insurance. So I'll just go to the doctor, get a prescription. It's a $50 office visit. She didn't realize the medication she'd been on, sertraline, is $4 a month. So the cost of treatment may not be as high as you think it is, and there are resources as well for that. Okay, I'm worn out. Who's got questions and answers? We've got about 5 minutes left. If you've got answers, I really want to hear from you. Questions too. Please unmute yourselves, and I'm happy to try and answer or clarify anything else, or if anyone has something they want to mention that you realize I forgot, please say something. Anything?
I actually have a question.
Yeah.
So I guess this relates to mental health in men in particular. So I'm in a fraternity at school, and I'm in a position in that fraternity, and I would love to like find some way to sit everyone in like my fraternity down and have them talk about mental health and kind of just like how they're doing. Like, is there an activity or like something that you can think of that would be like an effective way of doing that?
Yeah, Darren, that's a great question. And I love that you're already reaching out and wanting to take this to people who may need to hear it. I have some ideas, but my best friend, bizarrely, is a thoracic surgeon who just went back to do a residency in psychiatry at U of M, and her husband is a professor there who chairs, long story short, a department having to do with mental health and substance use, and has a particular focus and interest in men for obvious reasons. Shoot me an email and I'll hook you up with those guys, or I will talk to them and get his thoughts on that, which I think will be even more valuable than my own. Thanks, Darren. Make sure you email me because I want to follow up on that.
I have a question.
Yeah.
My son is 12 and he's been seeing a therapist,
Mm-hmm.
and they kind of realized that he has anxiety. But the thing is, he's seeing the therapist now twice a week,
Yeah.
and he's doing yoga and he's doing acupuncture, but we realize it's still not helping. And what else do you think we could do to help him out?
It sounds like your therapist is attentive and creative in his or her ideas. First of all, kudos to you for getting him into therapy. I think we way underutilize it. I used a therapist for my kids, and I think they would tell you now that's super helpful. I think there's still a stigma, which is incorrect. So kudos to you to getting your son into therapy. It sounds like she's got a lot of really good creative ideas. I would trust a therapist like that to, one, answer the question that you just asked, and two, have a low, I would expect that therapist would have a low threshold, or would be quick, in other words, to say, hey, I think medications could be really helpful here. Let's get him hooked up with a psychiatrist. Exercise and diet are super important. And, you know, men who are in their teens and 20s, I always think of deer in the woods. You know, they run through getting their antlers hooked on everything and rutting. They're like, he's testosterone poisoned and about to be more so. So that's challenging in and of itself. And Darren, for sure, your fraternity is experiencing pervasive testosterone poisoning. This too is a manageable condition, not a genetic defect. You know, just talking about that kind of thing with him and saying, hey, I was never a teenage guy, but I know there's a lot of changes you're going through. Exercise will be important. Diet will be important. Sounds like you've got a great therapist.
Yeah, one more thing. The thing is, we see that he has school anxiety,
Mm-hmm.
and I cannot understand. He's doing really well, but it's like once school starts, he gets sick, physically sick. He has pain crisis. He cannot sleep at night, even though he's getting A's.
It is not a quick fix. That is super complicated, and some of that may be PTSD. He may have had some bad experiences at school, people bullying him, not understanding his disease. So that's super complicated, and I can only tell you this is not a sprint, it's a marathon. He will get well. He will be able to go to school, and just to be patient and believe in him, which I know you do. Thank you. I really appreciate it. Any other questions? All right, well, let you guys practice some self-care and go to the bathroom, get something to drink, whatever you're going to do before the next session. Thank you so much for listening to me babble on. If anybody has specific questions, My email is becky@northstarreach.org. And any of us here at North Star Reach, we want to go the journey with you guys. So reach out. We love you. We believe in you. You guys are heroes. And we look forward to talking to you soon. All right. Take care. Bye-bye.